The British Association of Dental Nurses, proudly supporting dental nurses since 1940.
With a very strong commitment to professional standards, education, and clinical best practice, Carolyn is very passionate about supporting dental teams in understanding their roles and responsibilities within patient care. So during this session, she will be exploring the important and often debated issue of clinical note-taking, drawing on guidance from the GDC and indemnity providers to help clarify professional expectations. So, Carolyn, on to you.
BADN members have access to our legal helpline for free legal advice.
Oh, thank you ever so much for such a lovely welcome. And I was just having a browse at everybody on the second page of the screen, and I'm already jealous of everybody that sat outside. So a massive thank you for joining us on this lovely day again. Yeah, thank you very much, Preeti. So I won't keep you too long. Let's get cracking. I'm going to share my screen with you. Like Preeti said, just put any questions you have in the chat or pop your hand up, and then we'll take. Oh, thank you ever so much for such a lovely welcome. And I was just having a browse there. So just because can everybody see my screen? Give us a thumbs up or a nod or anything. Yeah, perfect, lovely. So like I said, I'm Carolyn Roberts. I'm President-elect. I've been a dental nurse for over 35 years, working 26, nearly 27 years in community. And a question that often comes up is around who does the notes for who. So the aims and objectives for today, I'm going to clarify the position of the GDC, although they haven't come back to us with an actual statement. What I've done is I've just looked at their standards and their scope of practice to help inform this presentation. And also we've had a statement of our indemnity. So if you're with BADN and you've got indemnity with our underwriters and you've got a policy holder with us, then I'll give you a little bit about that in a minute as well. And just to identify some best practice and GDC learning objectives B and C if you want that for your records. So to write or not to write, that is the question. What do you all do, and what are your thoughts on clinical note writing, note taking in things? So I'm quite happy to take a few little thoughts and questions here if anybody wants to pop their mic on. And is anybody comfortable, uncomfortable? Is it the role of the dental nurse? Is it not? Anybody got any thoughts? Check the chat. Got nothing in there. Okay. Oh, yeah. Treaty.
Just so that we're not quiet and we make this interactive. Well, I do believe that, yes, we do take notes. I take notes for my clinician as well. But he always double checks because we both know and believe it's his responsibility. But I could be wrong. But I will wait for you to clarify that for us.
We'll take a dive into that. And I believe, Joe, you've got your hand up as well.
Hello.
Hiya.
Hello. Hi. Yeah, like Preeti. I think it's helpful to the clinician if the nurse makes notes while they're having a conversation with the patient, particularly, at the start of the appointment when you're taking the history or whatever. And then, like Preeti, they can read over it and edit it at the end of the appointment, however they want to save it.
Yeah, lovely. So this is what I've done. I've done written notes, and I'm now on digital platforms as well as a lot of people are on digital. I'm hoping there's not a lot of written clinical notes, but you may still have that. So what sparked me on with this presentation was actually where I work. And one of the nurses turned around and said, I'm actually not allowed to write in the notes. And I went, let me just double check that. And so I went on a little bit of a deep dive into what should we and shouldn't we doing for note taking. The other aspect as well is, as we're now, especially in the new contract reform in England, where they're expecting DCPs or dental nurses to apply fluoride, we'd be expected to write our own notes in that capacity. So we'll just have a look and see exactly what is good note taking, best practice, and how we can protect ourselves, the team, and the patient when we're doing that as well. So let me move this along. So I'll read off the screen a little bit. I might just deviate a little bit as well, so just bear with me. So we are increasingly being asked to write our own notes as our chairside duty and also part of our own note taking, especially if we're conducting a standalone clinic sessions. Some of us have got post qualifications. We hold our own clinics, so we'd be expected to write our own notes in those respect. But as part of the team, exactly like Preeti and Joe mentioned, part of a clinical examination, when the dentist is doing an assessment, we'd be using that. We'd be doing the charting. I mean, Sigmund Palmer, FDI, whatever you normally use. So the key message is here, and I was looking into this because I recently sat my immediate life support as well. Note taking is a professional skill and not just typing. And the Research Council actually classify the role of the scribe in medical emergencies as an essential non-technical clinical skill. So you do need to be clear, concise, and all that as well. So why does it matter for us? So it is actually a core professional duty. Record keeping is essential for patient safety, continuity of care, and professional responsibilities for dental nurses. The legal and regulatory importance, high quality records protect dental nurses during complaints or investigations by clearly reflecting events and decisions. Touch on professionalism and teamwork. Well-written notes demonstrate professionalism, scope awareness, and support effective team collaboration as well. And risk reduction and clarity. Clear, accurate records reduce risk and provide clarity, showing dental nurses acted appropriately in patient interests and within our scope of practice as well. So the GDC scope of practice, what does it say? So if you go to section 2.3 in the latest scope of practice, it says, what do dental nurses do? Dental nurses work collaboratively with other dental and healthcare professionals, making appropriate referrals and providing support to colleagues and patients in all aspects of dental care. Below are some examples of the tasks that dental nurses generally undertake following registration. They list a whole host of things, and within that is recording and maintaining accurate patient records. So it is within our scope to be able to do that. So GDC scope of practice and accountability. Accountability for clinical notes content remains in the most part with the clinician who oversees diagnosis, treatment plan and delivery of dental care. So exactly right, we're getting the clinician to double check, especially if we're in that clinical assessment appointment. If we're dictated to and we're typing notes or scribing, then it is up to the clinician that day. The dentist has the overall arching, but dental therapists with their ability to use, it's escaped me, but you know what I mean. So dentists can actually do some prescribing as well, dental therapists, sorry. So they are the ones that have to check the notes ultimately at the end of the day for accuracy, content, and all that. So would we be accountable? Maybe I've used a strong word there, but when we're delivering our own care in our standalone clinics as dental professionals, as dental nurses, if we're having our own clinic to do dental health education, radiography, CBT sessions, fluoride application, so on, we're going to have to write something in the notes, aren't we, that we've seen that patient and we've carried out that treatment. So adhering to GDC standards promotes the professionalism, trust and protection for patients and the dental team members alike. So we looked at the GDC principles, and principle 4 is maintain and protect patients' information. So this was basically going on accurate and timely documentation. So we must document patient interactions clearly and contemporaneously to ensure records reflect events accurately. That's every little thing. So if we're on the desk and we're taking a phone call, we have to put notes in the patient record, whether that's digital or written. They have to be legible and understandable. So if you're like me on the slate and the chalk, or on the paper and the pen, they have to be legible and understandable. Patient records must be easy to read and comprehended by other dental and healthcare professionals to support continuity of care. Amendments and transparency as well. All records amendments must be dated, explained, and must not be obscure the original entries. So if we have to delete something, we don't scribble it out, we date it correctly, we just put an entry in going, that past entry was incorrect, updated entry is this. So it doesn't look like records have been falsified. So they should never be altered or deleted to avoid any impression of dishonesty or anything. There's GDC Principle 6, working effectively with colleagues and collaborative patient care. So GDC Principle 6 emphasises teamwork among dental professionals to prioritise patients' best interests through effective collaboration. Again, it talks about accurate record keeping, clear and precise documentation, supports shared care by reflecting roles and responsibilities accurately within the dental team. Benefits of clear documentation. So accurate notes promote continuity of care, reduce misunderstandings, and protect professionals if decisions are questioned later. So when I'm with my dentist working, it's all about communication between myself and the dentist. Now I work in a community setting and I work with one dentist mainly, but I can work with any dentist. So if I'm going to work with a dentist I haven't worked for a while, or a new dentist, I'll have that conversation with them and I'll say, do you want me to write your notes? Or some dentists prefer to do them themselves, or therapists prefer to do their own note keeping. That's absolutely fine. But when we're just, when we're just asked to do the notes when the patient's there, it's about communicating right in the beginning of the day in the safety huddle, hoping you guys all have safety huddles as well. So it's about two-way communication. So it's ongoing, it's two-way between the clinician and dental nurse, and it ensures accurate and meaningful clinical notes. Good communication fosters teamwork and empowers dental nurses to clarify uncertainties and share responsibilities. Using the agreed verbal cues, structured handovers, and post-treatment summaries supports clear, consistent communication. So it's about, if you have a huddle in the morning, or a team debrief or a team brief in the morning, it's a good point there to actually talk about note-taking. If you've never worked with that person before, what are their usual acronyms that they use? Because if anything is questioned later, you'd have to explain any of the acronyms. We've got a dentist that uses ANK, and none of us knew what that meant, and it was appointment not kept, but we were used to FTA or DNA. So it's understanding what these little differences are and nuances between our clinicians as well. And then when we are actually being dictated to or taking the notes for the dentist, it's about actively listening to them and asking questions to confirm that you've understood, to avoid any inaccuracies and in record keeping. So clarification. I mean, hopefully you can tell by the white hair, I'm in my 50s now. My hearing is not the best. It's definitely a lot worse having 30 odd years of a drill by your ear. And it's, sorry, can you just repeat that? And that's the part of communication with your clinician. And if you haven't heard it, be honest. If you didn't hear it, don't write it down. You can ask the patient again, sorry, can you just repeat that for me, please? So what kind of language can we use? So we'll go into a bit more about some things later on, but when you're talking with your clinician, especially if you move from one clinician to the other, or a new clinician's come, you go, can I just clarify that last point? What wording would you like me to document in this instance? I need to check just before writing this down or typing this up. So it can feel a little bit daunting sometimes, especially with a new clinician, somebody that you're not used to working, but it's definitely one thing that you should never be afraid to ask for clarity, because it is important when it comes to accurate record keeping. So attribution and role clarity. So it's important as well to just say that you're actually you were dictated to, so you're taking these notes on behalf of the clinician, dentist or dental therapist. So when notes are recorded on behalf of a clinician, it's protecting you as well and your role, so that there's no ambiguity of who's written what. So if you're typing it up, you could put down Carolyn, dental nurse, dictating notes from dentist X, therapist Y, and then it's clear and set there. Or if it's writing in the records, dentist performed examination assessment, notes scribed by myself on behalf of. So it's those kind of things we need to look at. It supports good team communication as well. So good attribution clarifies responsibilities and enhances communication in multi-professional dental care teams. And professional and regulatory compliance. Consistent attribution demonstrates professionalism and adherence to regulatory and indemnity requirements as well. We'll touch a bit more on that again later. So scope safe clinical phrasing. So I'm going to move a little bit more into a little bit of language and what we can use. So the importance of scope safe language, and what I mean by that is identifying, again, it's the attribution. You're the dental nurse here doing the notes, but in what capacity? Are you the chair side nurse or are you the clinician nurse? So it's kind of using that, just making sure that you're sticking within your scope of practice. And it ensures that we're documenting clinical appointments accurately.
Your new destination for learning, growth, and career development as a dental nurse. The Edu portal gives you access to exclusive partner courses with special member discounts.
We're not implying clinical judgment, because as dental nurses, although we're coming a long way, we're not allowed to diagnose and we're not allowed to give a clinical judgment. Old timers like myself, we can see an x-ray and we think that looks like a cyst, but we wouldn't be able to write that down because that's not within our scope. We know what it possibly is, but we can't do that because that's then turning into diagnosis and a clinical judgment, unless it is within your scope to be able to do that. So clinical roles, like I said earlier, the examination was carried out by clinician, name, and notes dictated to, name, and clearly assigns the clinical decisions to the correct professional. Compliance and protection as well is important. Using scope safe phrasing helps dental nurses comply with standards, and it protects us as well during record scrutiny, indemnity claims. Because if you're just writing something down ad verbatim and it's in your handwriting, there's no record that you've actually been dictated to. So it's one of those things. So when we are writing notes, it's just about, I think we should just be quite clear with it. And it's just, again, the type of language that we use when we are writing clinical notes, that it's important to use objective and quite neutral language as well. And that ensures clinical records reflect direct observations without judgment or emotional bias. Neutral language benefits, respects patient dignity and reduces the risk of records seeming unprofessional or biased. When I first started dental nursing, I was in a local practice. If you know where I live, you know which one I mean. If you don't, you've got no clue. But basically, I've learned so much. We used to have written notes, and the dentist then, it was back in the late 80s, used to put little bits on the record that weren't appropriate, like PITA, pain in the, and then the one that actually really hit home was we used to work off 2 different floors, and you'd go in on the street level, you'd go down to the basement to the other surgeries, and the receptionist would hand the patient their record card to take down with them. And this patient, bless them, young child, and on the front of their notes was adopted, and they did not know that. and that was absolutely horrific. So all these rules, regulations come in so that we're not disclosing information that we shouldn't to the patients either. So, you know, it's shocking when you see something like that and you've just absolutely destroyed somebody's confidentiality in that moment and everything, and it's quite thing. So it's neutral language. You don't need to put all those extra bits and bobs in clinical notes unless it's pertinent to that person, but it shouldn't really be visible.
BADN members have access to free CPD in our quarterly digital journal, in our CPD portal, our online coffee catch-ups, and to our downloadable CPD activity log and professional development planner.
Anybody to see. So the golden rules are recording facts only, actions and observations. Attribute any findings and decisions to the clinician or patient as appropriate, and use neutral and objective language. So I've got some phrases that we can use. So observation phrases: patient appeared calm, anxious, upset. Swelling noted extraorally. That bit you could say by clinician here as well. Bleeding observed post-procedure by clinician, yourself if it's within your scope. No adverse reactions observed. So taking an objective route, it describes what you're seeing, not what it means. And then when patients are reporting information, when I take my notes, I'm sat there and I'm listening to the conversation, what the dentist is telling me, but also what the patient is telling the dentist as well. And a bit of social history, the dental history, medical history, that quite often you've looked at the medical history that they filled before coming in, but then there's that extra little bit that the patient divulges afterwards. And, you know, so it's recording all that as well appropriately. So it's stuff like patient reported pain, lower left 6, patient reports a pain score of 5 out of 10. So you are just recording facts. You're not saying patient looks like they've been in pain all night. You're not being subjective to it. So patient stated that the tooth was painful for 1 week. So you're just reporting the facts. Supporting the clinician. So sometimes you can write down assisted clinician during examination, chairside support provided, procedure carried out by clinicians as planned or as per treatment plan, instruments passed and aspiration maintained. It makes your role clear and defensible as well. And radiographs and procedures. If you take radiographs during that examination for your dentist, radiograph taken on clinician's prescription. And this is really important as well, especially when we're using our own scope. And if we're doing our own dental nurse-led clinic, we can write radiographs prescribed by dentist X. Today patient came in, fit and well, no changes to medical history, so on and so forth. And you can say applied fluoride as per prescription by the dentist. Impression material prepared for the clinician, local anaesthetic administered by the clinician. I'd continue there by putting the batch number and expiry date of the local anaesthetic, just to complete the logs as well. And try and link the action to the prescription or instruction, especially when we're seeing the patient ourselves. Consent and explanations as well, because consent is quite important, obviously, and it has to be documented. And I think the dentist or therapist should be doing a lot of this part of it, in my own opinion. But if we were helping, then we'd put down, well, the procedure was explained by the clinician, patient given opportunity to ask questions, patient confirmed understanding, consent confirmed by clinician, consent form signed. Again, a lot of these digital systems have got that, so you've got all the timestamps on them as well. Anxiety, behaviour and special care. So the patient appeared anxious, reassurance provided. I'm sedation trained, and quite often we see very anxious patients. So we'll put down that supported patient by holding their hand. help them out of the surgery, especially we see elderly patients as well. Additional time allowed for the patient, rest breaks offered, care a relative present. We've got one young lady who's a selective mute that we treat at the moment, and she won't come in for her treatment without her mum being present. And we've built up quite a good rapport now that actually she's starting to open up and she's verbalizing a lot of things herself now. And that's really good because we've taken the time to do that. But in the notes we're recording, patient has now begun to speak with us because she's become quite comfortable. So this is really good for community dental services, especially if that's the type of patients we see. However, maybe I'm being very biased there. How many of you work in practice and you're just as caring with your patients as well? You know, we all see a lot of patients, don't we? Infection prevention and safety. So standard infection control procedures followed, PPE worn as per policy. That's a good one. So you'd put down that we were all wearing PPE. Surgery cleaned and prepared post-procedure. Instruments decontaminated in line with guidance, especially if you're doing instrument tracking as well. Post-operative advice given verbally and written. When I was looking at this, a lot of the post-operative advice, they do recommend that it's the clinician doing that. But I think I'm happy to do it now. I don't think it's anything, as long as it's written and we're giving it to the patients, I'm happy to go over those aftercare ad verbatim in one way. So I'm reading it off the pamphlet. I'm then handing it to the patient. So I'm happy doing that, but it is down to the clinician to give most of the aftercare. But I'd be happy to do that as long as you're writing it down. So you'd be post-operative advice given as per information leaflet, information written, information given as well. Patient advice to contact service if concerns arise. So it's short, concise little sentences. But we shouldn't do. We shouldn't delay writing notes. Records must be contemporaneous. They should be there and then written. Ideally, as soon as the patient has left the surgery. So this is where we come in as dental nurses. If they're doing an assessment appointment, then it's important that we write those notes. Well, not important that we write them, but it's important that we work as a team to write those clinical notes as they happen. I used to work with a dentist years ago that used to do all his notes at the end of the day. Hats off to them. I couldn't remember what we saw first thing in the morning. By the time we'd reached 8 o'clock at night, I was cream crackered. But that's how they used to do it. But these days, it is better to try and put it in as soon as the patient has left. We shouldn't be using vague entries like patient was fine or treatment done. We should be putting down exactly what treatment was done. So if it was a composite filling, was there a lining used? What was the local anaesthetic? Expiry date, batch number. Mustn't miss out consent discussions or advice given. So you've got to record those as well. Mustn't be using our judgment or personal opinions about our patients. And we mustn't forget to record who did what, role, initials, date and time. Mustn't use unclear or non-standard abbreviations. Shouldn't alter or delete records without explanation and date. Mustn't ignore patient concerns, questions or refusals. And we mustn't record opinions instead of facts. And assume no note, no problem. So if it's not written down, it wasn't done. So it is very important to keep really good, accurate notes. So thankfully, we live in 2026 and the pen and paper hopefully is disappearing as quick as we're still in the community. We're still half and half. We're going as paper light as possible. But I'm hoping that a lot of you use digital systems. So some of our digital systems, they actually have a dual logging. I use Soul Health in my work and I know that they've got a dual logging, so you know who's writing what part of the notes, and that's really good. So you can see that it's you that's inputted on behalf of the clinician's actual appointment. And you've got your own logging if you were doing your own clinic. If you were using fluoride radiography, you can have your own logging as a clinician as well. Again, as Preeti and Joe said, it is the clinician's responsibility. They must check what we've written because it's their treatment at the end of the day. They must check it for accuracy and completeness and formally countersign them to confirm professional agreement. If that's on a digital record, the digital timestamp and the separate loggings is a good way of doing it. And the governance and compliance of it all. Software tools properly ensures compliance with professional standards and demonstrates strong governance in clinical records. So I've got some examples of some performers here. Those of you in NHS, I'm sure you might all be familiar with the FP17. On the other side, I've used various different proformas over the years. We've had a stamp for the written ones. Again, the digital systems, you can input a proforma. So if it was a new patient assessment, you can add what you want there. If it's a recall checkup, you can add something. If it's a filling, you can add a proforma in for it. Where I work, we do have some dental students come up from Cardiff University, and they've inputted loads of different proformas for when they're doing IHS, when they're doing extractions, when they're doing fillings. So it's all there. It's not memory based, it's a proforma. So if you haven't got proformas on your digital system or written records, then I would really recommend you go away after today, discuss with your teams and create proformas for everything. And then you've got the same abbreviations for each patient. Like you can see on the screen here, there's loads of different ones. And this next one I'm going to show you, because I do work in sedation clinics as well, is what we have come up with as a service for recording a conscious sedation appointment. So we'd start with the dates, location, patient name, the date of birth, whether they're male or female, where were they referred from, reason for referral, and this is for every appointment. So regardless of whether we've seen them 10 times or not, we're still filling in the same proforma. We might know the patient extremely well by now. We know that it's the left antecubital fossa or the right dorsum of the hand that they have the cannula in, but we still write it down because every day's a different day. Life happens, unfortunately. We come into work, we try our best to be 100%, but again, sometimes we're not. And this is where the proformas actually come into their own, because it's a cue as well. Have we done this? What's the relevant medical history? Social history, because when we're sending them home after sedation, we need to make sure that there's somebody there with them. So I've taken away our branding, obviously, but this is the kind of thing we'd be looking for. ASA levels, what their saturation levels were, observations during the procedure. And in the end, what were we giving them? Did we give them any intraoral examination? What was the treatment? This then is scanned into their patient records, and we've completed the chart as normal as well. But then we've got who the actually anaesthetist was, if it's anaesthetist-led sedation, the sedationist, the dentist, who's a trained sedation nurse, and it's just slipped off the bottom there, but the second nurse as well. Who's the escort for the patient, all those information, so we just don't forget anything, and we fill this out for everyone. So proformas are really, really lifesavers. So things we hear when we talk about note taking, anecdotally. If it isn't written down, it didn't happen, and that's correct. If we don't write it down, then if anything did come up with a GDC or anybody, then it's indefensible. You can't argue that it's not written down. Good notes tell the story of the patient, and that's a really good one to remember as well, because that'll tell you that the patient has come from their assessment to having treatment with sedation to not needing sedation, and it tells a good story. and it tells you exactly what happens at each appointment with each professional. The palest ink is better than the most retentive memory, because again, life happens. And if I were to ask each and every one of you, what were you doing this time last Saturday? How many of you could tell me accurately what you were doing? You can give me a clue. I can't remember. I think I was probably down in my mum's having a panad and a cake, most probably, because she's an old school cook. But I couldn't tell you exactly what I was doing. Was I watching something on the telly? Possibly. Was I walking the dog? I really can't remember. And that's more about me than it does about yourselves. But again, with the patient, if we haven't written it down, then why are we not? We need to be writing it down. And again, the palest ink, I love this one, is better than the most retentive memory. So it just stresses the importance of how we have to write it down or type it in. Write it as if you need to justify it, because one day you might, and we're absolutely don't want that to happen, but we never know. And complaints are complaints, and patients make complaints, and professionals make complaints. So write it as if it's going in front of the GDC that very moment. You can't go wrong with that one. Clinical notes are not written for today. They are written for the future reader. So it's always there for the next person to see what happened. So if I won the lottery tonight and I didn't go into work on Monday, I mean, there would be signs of more than just not going into work. I might be able to put a full tank of petrol in my car as well. But yeah, it's there for the next person, so they can see exactly what's happened to that patient. And that just helps build the patient story and the patient experience. So this is a bit about indemnity. So indemnity supports dental nurses during complaints and investigations when acting honestly and within their scope. And if you are a member of the BADN with indemnity with ourselves, then they have said that in practice, we'd expect our policyholders to be adhering to the GDC guidelines. So we've touched on the guidelines with note taking, including the scope of practice. We mentioned that as well. And any cover offered under the policy is subject to the policy terms and conditions. Within this context, dental nurses are able to support the dentist or dental therapist by recording clinical notes, but the dentist remains the responsible clinician and should therefore sign them off or check them for accuracy and content before they are saved to the patient's file. Any nurse or any dental nurses recording notes should ensure the quality of the note taking meets expected standards of competency. So that was a short statement from our indemnity providers. So the importance of accurate records, high quality contemporaneous records, strengthen a dental nurse's position and enable effective indemnity assistance. Limits of indemnity coverage may not cover dishonesty, falsified records or deliberate practice beyond our scope. And record keeping as protection, follow the best record keeping practices, reflects integrity and upholds full indemnity support. So in summary, note taking is a professional skill, not just administration. Dental nurses may write notes within their scope of practice, and note taking must be accurate, contemporaneous and legible. So diolch yn fawr iawn. Thank you very much, everybody. And thank you for joining me on such a lovely afternoon.